Thank you so much for joining today, and thank you for the opportunity to Lynn and to Jade. I'm so happy that Su-yin's here. I'd like to mention that Su-yin was my PhD supervisor, along with Professor Rick Edemer. As Lynn mentioned, I'm a nurse educator for Biopreparedness at the New South Wales Biocontainment Centre, but also I'm an early career researcher at Wimmer. My mentor at Wimmer is Professor Lynn Gilbert, who is an amazing and wonderful mentor. And I do need to point out that my research is currently funded by the Prize Centre for Research Excellence. So today I'm going to talk about video-reflexive ethnography. We often call it VRE, which is difficult in when we're working with infection control, because VRE is also one of the superbugs that's around, but so I don't have to say that long word each time, I'll say VRE. It's a method that's been pioneered here in Australia, and it's now used internationally to address patient safety issues, including infection prevention and control, which I'll shorten by saying IPC. This presentation includes some footage of patients and staff that have given me permission to show you in this forum, but not outside of here, so please don't record any of this session yourself. There are some, and I can tell you which bits of video are actually available on the internet, so you can use them if you ever want to use them as examples, but there are a couple that I don't have permission to use outside of my sessions. So video-reflexive ethnography, VRE, is a methodology that's about dealing with complexity. We all know that healthcare is becoming more and more complex. The patients we care for are more complex treatments, technologies, and healthcare workers and patients are constantly adapting in response. So for a while now, I've been working with a group of researchers who seek methods that help us get closer to that complexity, to understand how healthcare workers and patients are learning to adapt and cope with it. So I'm going to explain the research project and illustrate it with some examples of projects we've conducted to embrace this complexity, especially around infection transmission in hospitals, and particularly around how patients perceive care and how they are involved in IPC. Just a little bit of background though, for those of you who aren't fully across IPC and healthcare-associated infections. Healthcare-associated infections are a major patient safety issue. In Australia, around 165,000 healthcare-associated infections occur every year, and many of these are preventable. So they're causing needless pain and prolonged stays, and sometimes even death for patients, as well as the huge costs for healthcare services. So over the years, a range of strategies and guidelines have been developed. These are largely top-down approaches. They centre on rules and guidelines. They're developed by experts, often through research, and they're promoted through education and monitoring of staff compliance. I think a lot of you probably have heard of the 5 moments of hand hygiene, and that's a good example of one of these strategies. And look, these have been successful. Many of them have been successful, but progress has been slower than expected, and healthcare-associated infection still remains a huge and ongoing problem worldwide. And of course, we've seen this acutely with the COVID-19 pandemic, where despite guidelines and education, the disease is spread in places like nursing homes and hospitals and other settings like hotels and cruise ships. And I'd argue that that's in part because there's a greater need to engage with the complexity of how those rules and guidelines are actually playing out in everyday practice, not just, you've educated someone and therefore they'll do it. And I'd also say that these guidelines largely focus on healthcare worker practice. So the patient with the most at stake have historically had very little involvement in either infection control or in research around infection control, although this is starting to change. But we do know that patients are willing to be involved in infection control, but they face a lot of barriers and challenges trying to collaborate with healthcare workers to do this. The literature actually tells us very little about healthcare worker views on patient involvement in infection control. We know that on the whole they accept that patient involvement may improve services and safety, but at the same time they're given very little advice or support or encouragement on how to involve patients. And they sometimes often hold narrow views about how patients should be involved. So they're possibly more likely to accept traditional roles, like patients maybe checking medication, over some kind of activity that perhaps expands a patient's role, like getting a patient to ask a healthcare worker to wash their hands. Getting patients to ask healthcare workers to wash their hands is probably the biggest involvement patients have had in IPC. And this particular integrative review looked at research focused on that. And they conclude that the simple messages promoting patient involvement may lead to complex reactions in both patients and healthcare professionals. It's unclear yet how patients and staff react to such messages in clinical practice, and there's a need for deeper understanding of how they can work together to support harm-free care. So there's a real need for research examining the actual context of clinical care interactions. But while many of these commentators call for new approaches and different kinds of research around patient safety, they actually fall short of articulating a clear pedagogy for how this might be achieved. So, video-reflexive ethnography does offer one pedagogy for assisting researchers and healthcare workers and patients to gain traction with and manage everyday healthcare complexities. It's anchored in learning theory, so it draws on the work of learning theorists such as Biester and Dewey and others, as well as affect theorists like Fox. And it's to capitalise on the learning that occurs as a response to being confronted with taken for granted ways of being. So we're asking people to engage in reflexive analysis of their everyday practices, their everyday mundane practices, so as to become more aware of the complex and habituated nature of these practices. And what this does is it can result in an emotional response in the people, and that's the impetus for learning and change. So from this viewpoint, learning is contingent on being affected, and it follows from that the greater our power to be affected, the greater our power to act or to affect others. So we just want people to become more aware of and more affected by the strengths and opportunities for change that are inherent in their shared practices and in their relationships, so that they can be motivated to reinforce or adapt them accordingly. What does it look like? Well, we work with participants to video their practices of interest, and we show them back to that footage back to them and to their colleagues, often in group reflexive sessions. So in the studies I'll talk about today, we videoed everyday IPC practices, swabbing patients, moving infectious patients from A to B, doing dressings. And we do this because we want to engage with the expertise of frontline staff and patients, because we believe they're a critical source of insight into the historical, local and contextual facets of how care is provided. And because this knowledge is critical to rethinking and reshaping how that care could be better provided. But the thing about this knowledge is it's not always explicit or articulate, because frontline actors are rarely given that time, and I know that myself because I'm a nurse, to step back and examine or reflect on the practices, especially together. But we have noticed with all the research we've done that when they're provided with the opportunity to watch video footage, they see the complex reality of that work, they become more aware of the taken for granted practices, but importantly, by paying attention to what's already in place, they become more aware of the strength of some of their existing practices and to be able to optimise them or to devise solutions to problems they see. So we often say to people when we're introducing it to them, it's a bit like sports stars watching themselves, footage of themselves to improve their performance, especially team sports. 4 guiding principles underline video-reflexive ethnography, and Su-yin has been really instrumental in pulling these, really teasing these out and getting them articulated well. The first one is exnovation. So exnovation is kind of in converse to innovation. Where innovation, you get something new and you put it in and apply it. Exnovation is about foregrounding what's already present, and it's a really big driving part of VRE. We want them to scrutinise their work practices and gain awareness of what's already there, how they're already creating safety and giving them more agency and control over what needs to change. And also VRE values learning as a social activity, so we want to facilitate collaborative reflexive deliberation to open up spaces for people to affect and be affected by each other and negotiate their different viewpoints. Third, reflexivity. So reflexivity instead of reflection, because we regard reflection as more a personal activity focusing on the individual and their past thoughts and actions, which is really important, but what we're aiming for is a shared social deliberation about things that are happening, their practices that are in existence now. And we believe video is critical to engendering this reflexivity on several levels, and I'll explain that in the next slide. And the final one's care, because such close scrutiny of practices and relationships can really create uncertainty in people. People get confronted with aspects of themselves and their work and their relationships that they might not actually have ever previously recognised or acknowledged. So we place great emphasis on the principle of care, and that the reflexive skills and the careful facilitation of the researcher are really crucial to it being successful. Okay, so why do we use video? Well, first of all, the moving image can reproduce the dynamics and complexity of everyday practice and makes them tangible and discussable. It offers it in real time, so it's not relying on our memory of how care happens. And as well as the practical and technical aspects of work, video can also connect people to the meanings and feelings embedded in their work practices and how these actually impact on their behaviours and on their relationships. We say that it's hologrammatic, so the people who are watching see more than the few minutes that we might show on screen. They understand the events that led up to what they're seeing, what happened next. They can link it to other aspects of their work. But perhaps the most important thing it links us to is our habits, and as I said, those taken for granted aspects of things that we've learnt not to see or learnt to forget, but that can still impact on safety. And it also shows us how we're collectively implicated in what we do. So it's not just that personal reflection, as I said, but how we as a team work together to give safe care. So this can be transformative. Masumi says in his book, Parables for the Virtual, he explains how watching the moving image transforms people by enabling the seeing of oneself as others see us. So in that moving image, we get confronted with a different view from the private mental image that we formed about ourselves, and then our understanding of how we act and relate to others might be a bit displaced. And that disconnect is that impulse for learning and the motivation for change. But as I said, that can create a vulnerability. We call it a productive vulnerability, though, because we do believe it's necessary for this learning and change to occur. Okay, so let's get down to the video. My PhD was part of a large NHMRC funded project. It was called Strengthening Clinicians' Infection Control. It was around trying to reduce MRSA transmission, and for those of you who don't know MRSA, golden staph, one of the superbugs that we have in hospitals. And video-reflexive ethnography was the main method used. So Su-yin and Lynn Gilbert will be talking about some of the findings from that study in a podcast that they're recording soon for Shern. So this is going to be some footage from that project. Su-yin was the senior researcher, and you can see her there in the middle facilitating a discussion. And up in the top right-hand corner, you can see some footage that the people are watching of a transfer of an infectious patient through a busy and crowded corridor. And while the staff are watching this footage, they notice that the corridor's crowded and people and objects, and it's a really tight fit. They're wearing PPE because the patient's infectious. But they start to notice that they're so focused on the patient that they're touching objects as they move through the shared areas, and they're potentially spreading pathogens around, and they hadn't realised that before. They're touching curtains and computers and an X-ray machine that's up the back. So I'll show you that now. Okay, so they decided from watching that they'll just have someone who goes in front to clear the path, and they did actually start doing that after this session. And so this is just one example of the many infection transmission risks that through Su-yin's work their staff were able to identify through the video reflexive process, and that was on 3 different wards across a couple of hospitals. So when I joined the project team with my PhD, I was asked to develop some research that would complement the video research that Su-yin was conducting, and I decided to promote a more central position for patients in the research. And just to set that scene, the unit that I researched on was different to the one you saw in that clip. There was a real problem with MRSA transmission. At the point prevalence at the beginning showed that like 42% of the patients were colonised, and environmental swabs also showed that this MRSA was out in the wards. You know, it was on the nurses' station, it was on phones, things like that. And the nurses were really upset because they felt like they were really trying to do all the right things. And some of them, I guess in frustration, had started to point the finger at patients, especially those who were known to be positive with a multi-drug resistant organism, because they were leaving isolation rooms and using the common areas and perhaps using the phones at the nurse's desk. And When I spoke to the patients, though, most of them told me that the staff had never had a discussion with them about what they could and couldn't do. And some of them admitted they didn't want to ask because they didn't want to stay in their rooms, be told to stay in their rooms. So it appeared that that nurse communication with patients was lacking, but it also highlighted why it's so important that these conversations do happen, because many of these patients were engaging activities that may have resulted in environmental contamination and in transmission. Let's keep going. All right, so I decided to focus on using VRE with patients to see if it could assist staff to become more involved, to help patients to become more involved in infection control. And I extended the methodology as it stood at the time. So first I did film everyday practices, and then the patient and I watched that footage back to look for infection risks and to talk about things that they do to keep themselves safe. And then I showed the original footage alongside the footage of the patient reviewing it back to the nurses that looked after them. And when the nurses watched this, they saw their practice from a really different perspective again, this time the patient's perspective. And seeing care through their patient's eyes disrupted their taken for granted ideas about how they interact with patients, because they started to realise their patients weren't receiving adequate information, and that patients were actually starting to watch their practices really closely and coming up with their own ways of doing infection control based on what they saw. But because the nurses' practices were sometimes inconsistent, not all of those patient strategies were actually effective. So it started to help to connect the nurses to the kinds of activities their patients were already engaged in, and it motivated the nurses to think about their own IPC practices as well as better ways to talk to patients and involve them more. So I'm going to show you a little bit of footage, an example of a patient demonstrating their understandings of infection control that was then later played back to staff. About what he thought was safe practice is disrupted there, and he comes to some new understandings about gloves and hand hygiene and safety. So this next one again, can go ahead. All right, again, please don't record this one. This is some excerpts from one of the reflexive sessions with the nurses, so I can show it here, but it's not to go outside of here. This is what happened when the nurses were watching back some of their patients, some of them who are still in the ward, talk about infection control. You can see it brings up some big issues for these nurses that go to the heart of what is patient-centeredness when it comes to infection control. What does it mean to be a professional, and is there dialogue across that boundary? Because there are quite a few conflicting ideas being bounced around even in that room. I mean, does being a professional mean having authority, or is it that you listen to patients and negotiate care? And does that include letting them comment on your clinical practice? Because one of them was saying, well, the benefits to that is they can help us reduce transmission, they can remind us we're only human. But then someone else saying, but how do you manage when you open the floodgates of that dialogue? So these are dilemmas that I, as a nurse, I've never had the chance to kind of sit back with people and talk about these things. Next. But one of the things that came out of this NHMRC study was that patients didn't feel they were getting enough information to protect themselves. Staff didn't really feel confident talking to patients about these things. So we came up with the Talking with Patient project. It was Su-yin, it was Ruth Barrett, it was Lynn, but also it was a collaboration between the ward staff that we worked with, some infection control practitioners, ID physicians and laboratory staff, and they all helped to develop and design the research, and they were part of it every step of the way. And the aim was to improve that communication around multi-drug resistant screening. And by that we mean the communication that occurs when patients are swabbed and when they find out that they have actually picked up a healthcare associated infection. We did the same thing where we videoed the footage of the clinical practices, showed it to the patient, showed the original footage back. But our team then analysed this in two ways. So we transcribed those reflexive sessions for two purposes. One, to disseminate the findings to academic audiences, but two, to provide organised feedback of the main insights and issues to a working party, and that was made up of researchers, nurses, an infection control practitioner, an ID doctor and the patient's relative. And the aim of that was to action issues and potential solutions raised by staff and patients. So you can see the kind of interventionist aspect of VRE. It's a research, but it's also giving immediate effects for the people who you are working with. All right, so I'm just going to do the final slide. Video reflexive ethnography used in these studies was effective for strengthening patient involvement because it was first anchored in a very different learning theory, which capitalised on that learning and change by looking at and disrupting your everyday ways of being. It used a democratic process of data collection and analysis because all the stakeholders are involved in decisions about what's filmed and the analysis of the footage, and sometimes in dissemination or creation of projects. By presenting footage of the nurse's everyday work alongside the patient's observations of the same events, it was possible to shrink both the research practice gap and the patient-clinician feedback loop by enabling the nurses to link what they do in real time and how this matches their own goals and matches the views and expectations of patients in their care. It's assisted everybody to examine the complexity of relationships and practices in situ, and for nurses to see that through their patients' eyes. And importantly, it made tangible and discussable not just the technical aspects of work, but the affective and emotional dimensions of care that impact on safety. And it acknowledged the team-based essence of how safe care is collectively negotiated. Very briefly, we've got a few other projects that are happening now. A lot of them are around high consequence infectious diseases. The top one that you see there is around using video to look at the processes that are happening into hospital and amongst other services. We've also got some work that we're doing around how to implement safe PAPA, which is an alternative to an N95 mask. It's a powered air respirator. And how we used video to help rapidly train people. So we're doing it that right at the moment. And we've also, even prior to COVID, we were involved in using video-reflexive methods to try and get people prepared for disease transmission risks. So I'll end it there because I know I've gone a bit over time. I have some references. I have some of the outputs from our research. And then I'll hand you back to Lynn.
Thank you, Mary. I'm sure if you can hear the applause.
It was that canned applause.
Oh, no. Of course not. I'd like to thank you so much for that, Mary. I'm going to give everybody 2 minutes to just engage with the Padlet. And Jade's just put the Padlet up again in the chat in case you don't have it, to just put some of your questions in there. And I'm going to urge you to also put your name so that I can call on you to ask a question. And so we'll just literally do it for 2 minutes. I can see there's lots of questions going up, but I'll give you time. If you don't have access to the Padlet, you can put your question in the chat.
Okay, so how do you want to do this, Lynn? You're just giving people time to do this, and then you'll tell me when you want me. I want Su-yin and I to answer some of this. Oh, she's already been.
I think we'll give everyone just some quiet time to write in the Padlet. It works best that way. And then we'll get stuck into the questions.
I can see Su-yin's already answering things, which is great.
Yeah, but I've stopped now. Everyone else is. That was fantastic, Mary. I love watching that video of, you're saying, well, what is the sterility percentage? And then pointing out, what not many staff realize as well about gloves.
But we seem to have some buzzing going on, and I'm not sure.
Me. It's always me, isn't it? I don't know what else to do about that.
I guess if you mute yourself and then when you're answering a question, unmute, I think that might be a good way.
And I guess while we're waiting for the questions to come through, Lynn, I just wanted to say thank you so much for inviting Mary and I to come and speak to everyone. It's always such a pleasure to talk about this work. And like for me, it's always a pleasure to listen to Mary speak about her work as well. And you know, as you can tell, you may tell, we're very passionate about it. And Mary is incorporating this into her current work as a nurse educator. So yeah, it's fantastic to get word out. Thank you.
I'm a real fan of your work. I'm going to move to the Padlet now and see if we can get someone to ask a question. I think Megan Phelps, are you there? Where are you? You left a couple of questions, Megan. I was wondering if we focus on, to begin with, the ethics question, because I thought that was a really
yes, I'm just interested in the practicalities of ethics, which I always have felt a bit daunted about. I've talked with you very briefly, Mary, some time ago about this, but just interested in how challenging it was to get permission from all of the people who might be kind of incidentally involved, so the cleaners or the porters, and whether that actually was an issue or not.
Funnily enough, I don't think it has been that much of an issue. Sometimes Su-yin and I find that when we go into a ward and you'll have some people, I want to show you things, but because we often do, what we didn't mention was that we often go in with interviews first, so people get to know you, they start to feel safe around you, you show them some examples of the video that you've already done, and they see it's not lights, cameras, action, they're not going to be criticised, we make them feel very safe, we make sure that we tell them, even if you sign this piece of paper to say that we can video you, we are not going to just pull a camera out and, you know, be there to train it on you. We will always ask you prior to videoing if it's okay. We will always show you your video footage afterwards to make sure you're happy with it. We will also always tell you if we are considering showing this footage to anybody and make sure that you're happy with this bit of footage. We will always ask you, do you want to be there when we're going to show that footage, or do you just not really want to be there and have to deal with that? So we make sure they understand that. And then there's still people who say, no, don't you bring that video camera anywhere near me, I don't want to be videoed. But after they've come to a few reflexive sessions, they're like, oh, okay, this is actually not as bad as I thought. Actually, I've got an idea that we could do. So it doesn't happen with everyone, but we found that happens quite a lot. Would you got anything to add to that, Su-yin?
No, I mean, I think what Mary's saying is that it's actually a lot of work, but it's not insurmountable, and a lot of it has to do with them getting to know you and seeing what the process is like. So we've got some strategies, like, you know, when you come in to present the research to try to recruit a ward or a group of staff, you know, when we talk about how we do it, we answer all those questions at the start and make sure that we address any concerns. It sounded like there was a question about this regarding to how you get permission from all the people who might be videoed. Was that?
Yeah, because I guess I've not having actually gone through that preparatory process that you're talking about. I wonder whether, you know, people like cleaners, porters, incidentals that you might not anticipate being around, but who might have some valuable, might provide valuable input as well.
Absolutely. So we do try to include as many people as possible and speak to as many people as possible. But, and, you know, you might say, okay, tomorrow let's do this, let's video this. But when you turn up, often there will be some new person, whether it's a medical student or, you know, a social worker who's come along. And so you have a range of things. We have a one-page handout we can give to someone so they can take away and read. We have a, you know, a 2-minute elevator pitch about what it's about, and always, constantly renegotiating consent.